All right. Thank you for joining us for Talking Hemophilia A, integrating novel treatments and enhancing patient outcomes. During this segment, we'll be discussing efficacy and limitations of currently available therapies in hemophilia A. I'm Dr. Jonathan Roberts. I'm the Associate Medical Director at the Bleeding and Clotting Disorders Institute, and I'm joined by my colleagues, Drs. Mindy Simpson and Guy Young. So thanks for joining, and we're going to talk about, in the first segment, Dr. Simpson talked about really some of the current challenges with managing patients with hemophilia A. And we're going to talk just in a little bit more detail of some of the novel currently available therapies that are in use currently. So, the things that have been available for a long time are the standard half-life factor concentrates. So just a little background for maybe those not familiar. They're plasma derived that are purified from blood donors that, in the 90s especially, had become more pure as opposed to the era of the 1980s when there was a lot of contamination with HIV, hepatitis B and C, that really kind of spurred on this novel innovation to make recombinant factor products and extended half-life products, and certainly we'll talk in Dr. Young's segment of some of the cutting-edge therapies that are currently in development. But right now, standard half-life clotting factors, like I mentioned, are plasma-derived or recombinant-based. Recombinant meaning that they're made with recombinant DNA technology in cell culture in the lab. And really, these factors, there's many different available on the market, but they all, in general, last around 8 to 12 hours in adult patients, even shorter in children, and have been the mainstay of therapy for many, many years. Around 10, 15 years ago, started to have extended half-life clotting factor concentrates. And so these are a few different molecules that use a few different techniques to try to extend the activity and circulation of the particular therapy. So some of the big concept strategies that have been used has been pegylation, where polyethylene glycol moiety has been added to the factor VIII molecule that actually helps to prolong its half-life somewhat in circulation. Another is with FC receptor that uses a different technique through the neonatal FC to actually recirculate some of the factor in circulation. And those really are kind of the two big methods in hemophilia A using extended half-life. But even so, the currently commercially available extended half-life products maybe increase the half-life by about 1.4 to 1.5 fold in some patients. And this is certainly variable from patient to patient and has really spurred on over the last decade the development of doing more regular pharmacokinetic profiles in patients when thinking about a particular therapy for a patient. And that being said, why have we not been able to, overcome that barrier? And really, it's because of the half-life of von Willebrand factor itself. And some of the other technologies that are being implemented are looking at overcoming this von Willebrand factor half-life as well, in some of the things that Dr. Young is going to be talking about. We've already discussed in the first segment about some of the factor non-replacement therapies. Currently, there's one on the market, emicizumab, that's a monoclonal bispecific antibody that's subcutaneous. So it's currently the only subcutaneous therapy for patients with hemophilia A for prophylaxis, and has seen a good efficacy in patients both with inhibitors and without inhibitors. Also for those patients who have inhibitors, and when I say inhibitor, I mean an allo antibody that actually neutralizes the factor activity in circulation. So as you can imagine, sometimes patients are exposed to a protein that they don't naturally make in their circulation, the immune system can form a reaction to it, thereby neutralizing the factor therapy that we're using to treat our patients. And so in that, there's a few bypassing agents that are used, two main classes, an activated prothrombin complex concentrate and recombinant human factor 7A that's used. And these are basically exploiting the coagulation cascade by a different mean than direct factor VIII replacement to thereby promote thrombin generation and ultimately hemostasis. The challenge with bypassing therapies is that they don't really last much longer than the standard half-life clotting factors like the APCC, and certainly there's a much shorter half-life of only a few hours for the recombinant factor 7A therapy. But nevertheless, for a patient with an inhibitor that's actively bleeding, whether they're on a prophylactic therapy, with emicizumab or not, still those are what we have available. I will also mention that combining an activated prothrombin complex concentrate with emicizumab, there's a black box warning, so certainly for causing too much thrombin generation, so something to pay attention to if you're considering that for your patients. So there's a whole host of therapies that are available currently, as of, Q1 of 2023. And so I have one case that I'll discuss and the thought process that went into choosing therapy for one of my patients. So I have an adult man in his early 30s that actually came to our center from overseas. And unfortunately, he had not had much access to regular factor replacement therapy throughout his life. So he has quite severe hemophilic arthropathy in multiple joints. It affects his gait. It affects, it affected his activities of daily living for sure. And he was just newly married. And, the first time I met him, the thing that he asked me is, I want to be able to go on walks in the evening with my soon-to-be wife, and I don't want to have a bleed. And just even ambulating for him was a challenge. So he was familiar initially with some of the standard half-life clotting factors, and he had pretty much in his home country whatever was available at the time, because there's much limited access, unfortunately, in countries around the world. And so we put him on a standard half-life prophylaxis regimen initially, because that's what his comfort level was. We had talked about all of the products that were available. At the time when I first met him, emicizumab was actually not available. So he actually, we trained him for home infusions because he didn't know how to do that. And we got him on some regular therapy. And then shortly thereafter, within knowing him for about a year, we're able to get him, warmed up to the idea of an extended half-life factor concentrate, something that he wasn't as familiar with, but we talked about the data available and reducing treatment burden, because it turns out that doing intravenous infusions for him was a little bit of a challenge. And so he was on extended half-life factor concentrates for a time. Fast forward to now, just within the last 2 years, as emicizumab has been available, and he was reporting some breakthrough bleeds with the extended half-life factor concentrate use, was doing in general a good job, but the conversation kind of developed to how can we do better in therapy. And so we actually ultimately made the decision to put him also on emicizumab. And so during that time, he's had a few breakthrough bleeds. But it's encouraged him to be more active. He's was a little bit overweight and has got on a regular exercise routine. He certainly now, as he's now married and has a young child in the home, has been more active raising a young toddler, and had some breakthrough bleeds with just overuse and in playful trauma in that regard. But now he's doing very well in emicizumab, and he still uses factor concentrates for breakthrough bleeds. So I don't really particularly have a question or a challenge, other than for my colleagues. Is this similar to stories that you've experienced with some of your patients? I know, Dr. Simpson, you take care of some young adults, but any differences in approach that you may have considered, with that patient?
No, thanks. I think it's a really classic story, especially for patients that come here from abroad. I think we all probably have some experience with similar stories. And I think you describe a lot of just of where the world of treatment in hemophilia has gone over the last 10, 15 years, which is really remarkable, right? So, so you brought somebody, you taught them how to do their infusions. They were presumably doing better, at least on prophylaxis of any variety, than they had, the rest of their life. And I think that's by and large the first story, which is, get them started on something. I think we all have adults in our practice as well that, didn't do prophylaxis as a child because it wasn't really a thing. And so we still work on some of our adults and trying to convince them to some degree that prophylaxis is helpful, even if they have, ongoing arthropathy and chronic complications, that, that we can still improve their quality of life if they treat more. So, I think a really natural transition from standard half-life, extended half-life to the novel therapies, and just the conversations that go into it. So it's the, patients have choices. So we have many patients that are doing really great on factor prophylaxis. They have to take it, for it to work.
Right.
And if it's not, it's such a nice time that there are options and there are newer things coming. If this isn't right, that, things to consider. So, no, I think we've had some very similar stories. We have many more coming that are
Absolutely.
Patients are transitioning from one thing to another, and patients are getting more comfortable with switching different therapies, where in the past people really stuck to one thing. And it was maybe what their family had been on in the past and things. So, it's encouraging that patients are doing better and better, even as they get older, by allowing them to try the new things.
Absolutely.
Yeah, I can add that. I definitely have similar stories. I think one of the things the audience should understand about the difference between the current factor therapies and emicizumab is, with the current factor therapies, one advantage is that you get peak and high levels. That might be important for somebody who's particularly active.
Yeah.
Well, on the other hand, emicizumab gives you a stable level. And so while you don't get peaks, the advantage is you don't get troughs either. And for somebody with advanced arthropathy, this notion of what we call subclinical bleeding, some people call microscopic bleeding. For patients who have joint disease, I think that may be something that we see happening when they start having some aches and pains. Maybe sometimes it's just arthritis, or maybe sometimes it's subclinical bleeding. And I think a drug like emicizumab, without having the troughs, potentially, and I emphasize potentially because it's not been studied and it's a hard thing to study, but by not having these low trough levels, it may help with that particular scenario. On the other hand, if you had a similar patient who had good joints because he'd been on prophylaxis and he plays basketball 3 or 4 times a week, perhaps for that patient, a standard half-life factor 8 where he can dose when he's active and when he's playing on those days may be beneficial. So I think really the message that I would say is that, there are patients for whom factor therapy, even standard half-life factor 8, may be more appropriate. Others for whom somebody like this who's not particularly active, does have some joint disease, just wants to be able to do a little more, walking in the park with his wife, playing with his kid. Something like emicizumab may be very useful, not just for the convenience aspect, but sort of not having those trough levels that might open the door for full-on bleeding, overt bleeding, or even microscopic bleeding. So those are my thoughts.
Yeah. No, thanks both for that. And I think, even one part I didn't mention at the beginning was having him newly coming to the United States was really humbling when I interacted with him, because you could tell he was having feelings of guilt even for having the discussion of being able to go on prophylaxis, because he knows what his home country resources were, and the fact that this has been so life-changing. I mean, even going on initially standard half-life prophylaxis was initially, very transformative for his life. And we just kind of kept tweaking therapy as we went on and on and on to try to make it better and better. And so it's really, neat to take a look back and see how well we did for this one patient, but really also a call to us, as a global community, how access to care globally is really needed. And I think maybe even some of the things that Dr. Young's going to talk about in the next section can help us maybe meet some of those goals of better access to care globally. So with that, we're about out of time. Thank you again for joining us for this segment on efficacy and limitations of currently available therapies in hemophilia A. Please be sure to click on the landing page for this activity to claim your AMA, ANCC, ACPE credit, access to supplemental slides, as well as other topic segments and case scenarios. Thanks very much.